One.
Okay, there we are. Excellent. Well, welcome everybody to this Catalyst seminar, which is being organized by the Center for Pediatric Mental Health Research at the Institute of Child Health. We've got two speakers, both from Great Ormsby Hospital and from the Institute of Child Health. Our first speaker is Lee Hudson, an old colleague of mine from, well, he's very young actually, but he's a colleague I've known for quite a few years. And you can see how he was determined to present as a doctor. He's in his scrubs, having just run from a ward. So unfortunately, he won't be around for the whole of the seminar. So if you've got questions for him, it's best to ask them immediately after his presentation. But I'm absolutely delighted that Lee was able to do this and to talk about a very important study that he's involved in, which is looking at the admissions to pediatric wards, so wards that are dedicated to children with physical conditions, but with mental health disorders. And this is a nationwide study, I believe, isn't it, Lee? So
yeah.
over to you.
Thank you. Thanks for a very nice introduction. I'm not feeling so young today, I have to say, but thank you. And just to hats off and just recognise and acknowledge the exec committee and the Paediatric Mental Health Sciences Centre at the Institute. And thanks for everyone's hard work on that. It's a really important project that's bringing together physical and mental health together. And thanks for the opportunity to present. So I've only got 20 minutes. This is quite a big study that's just coming to an end, actually. I apologise in advance because I can't give you all of my data, and I'm going to give you some tantalising insights to data, some things we haven't published yet, but that won't be recorded. But this is an NIHR funded study based at the Institute of Child Health, where I am co-PI for this with Professor Russell Viner. The inspiration for this, I've been a paediatrician, and despite the fact that David says I'm young, actually I've been a paediatrician now. I'm working in paediatrics for what will be coming up to 25 years. And at the very beginning of my career in a children's hospital, I was struck even at that stage by how many children who were being admitted to general children's wards, which is where you spend most of your time as a paediatric trainee, were admitted where as much of their issue was mental health as it was the physical health reason they've been admitted. And I particularly won't share details, but there's several cases that people have really struck with me throughout my career, and I remember. And some of those children were there because they got a physical health condition. It could be surgical, it could be other medical causes, but also being a primary reason for admission for mental health as well, and that we just really haven't ever been geared up to do that properly. So the children, so this is the mental health admission to paediatrics ward study, MAPS as it's called, and the focus really is on general children's wards, and those children who are admitted to a paediatric ward because of their mental health. So I'm not talking, and not saying that it's not important, but I'm not talking about children who, for example, are admitted with cystic fibrosis or asthma, and then someone finds out whilst they're in that they've got a mental health problem or a mental disorder whilst they're in. I'm talking about the children who explicitly have turned up in hospital, A&E usually, too well to go home, and so admitted to children's ward as a place of safety. This has been done through, I think, Charlie, you've got your microphone on. And so there are four themes to this. One was looking at national patterns of admissions, which is what I'm mostly going to present to you today. Two, a surveillance study where I've got a little bit of data to show you. Three, some qualitative work. So there's 15 children's hospitals where we're picking up granular data, and four is where we're at the moment, where we're coming up with a theory of change and presenting our data and already having some impact in terms of what's being delivered nationally and what's being monitored nationally. Key to this has been the involvement of young people. It's a massive project of collaborators from Royal Colleges to NHS England, pretty much every charity we could try and think of across mental disorders, autism charities, eating disorder charities, but critically, children and young people who've had lived experience and their parents have had lived experience, so they can. And it's been a real eye-opener to this to me. I'm sure you all use this in your research all the time, but I've particularly had to get better at it, and it's been a central part to this project for the last 3 years. And it's been a real eye-opener, actually, starting before deciding what we should research and look for and co-designing from the beginning to how we interpret the data and how we harness lots of different groups and lots of people's voices to impact the work and spread the word. We started with a systematic review. You may not be surprised to know that there was very little. There was nothing on national admissions. And the flavour I had heard as a paediatrician before the pandemic, actually, and during, was that from colleagues around the country, was that more and more children with mental health crises, as they tend to be called, were being admitted to general children's wards. And that was causing lots of problems for patients and families, because there are issues with the actual mental health professional provision on many children's wards. And also, I think generally recognise that many people are just not trained for this. We worked alongside the Health Services Investigation Bureau, which is the NHS's own safety investigation team, albeit independent of the NHS. And they did a report 2 years ago, which came out, which we've collaborated with and been a big part of, in terms of understanding the environment of the ward, in terms of cubicles, places for restraint, physical restraint. But the data was pretty lax. There wasn't very much at all. There was a bit of data telling us that young people weren't getting much communication, but we started from a baseline of pretty much very little. And all of these papers are published in open access, by the way, so if you want to access them, then you can. The national data is published in Lancet Child and Adolescent Health earlier this year in February. And again, that's open access. And that was essentially using HES data. So HES data is the NHS's sort of bill at the end of admission, if you like. It's not a research tool. It's actually a monitoring and financial tool primarily. But health episode statistics tell us something about admissions of children. And this was just England, because we at the NIHR funded this research in England. But this gives you information on virtually all, at least 97% of admissions to all venues in hospitals. So what we were interested in is looking how things had changed over time from 2012 to 2022, which is when we had the latest data. We have, by the way, just received updated HES data, which we'll be publishing on, or trying to update that, because the data that we had when we originally did this was only up to 2022. So what we looked for were children 5 to 18, so young people and children 5 to 18. Bear in mind that the vast majority of 16 to 18-year-olds are not admitted to a children's ward, they're admitted to an adult ward. So this data for those age groups will be adult wards as well as paediatric wards. So we looked at children who got a primary diagnosis of a mental disorder or mental health presentation in the data, where there was self-harm as part of an injury primary diagnosis, and also we looked for if they had been treated by a mental health specialist as an inpatient to capture those admissions over that period of time. And I'll go straight to the results for timing, and you can see that if you look at this is split down by age group, you can see in all age groups, all causes of admissions is the blue line, and mental health concern is the green line. And you can see that over that period in time, there's been a significant increase in mental health admissions compared to all causes. And it's particularly this group, the 11 to 15-year-olds, where that is most. So this graph, by the way, on the x-axis, you can see is year on year. And on the y-axis is the percentage relative change each year, so percentage on percentage increase. A dip, we thought we saw more admissions during the pandemic. There's actually a dip during that period. I think the key message here is that people tend to think this is a pandemic phenomenon. I think you can see that things sort of uplifted significantly the year after, so 21, 22 after the pandemic, in all age groups. But this is not a new problem, and this is something that has been going up and up since 2012 and probably before, but we don't have that data. It's particularly 11 to 15-year-olds, and if we break this down by age and by mental disorder or particular disorders. So in the 11 to 15-year-olds, there was a 600% increase in admissions of 11 to 15-year-olds with because of an eating disorder concern. But even look at the 5 to 10-year-olds, this is depression. So admissions, and these are primary reasons for admission. So they're admitted because they're not able to go home with depression. And that's a 400% increase in the 5 to 10-year-olds, which is concerning around that age group. But you can see in all ages, it's eating disorders that have mostly driven those admissions. What I find also very interesting in this data is substance misuse. And this captures a whole load of different reasons for admission, including in particular alcohol intoxication, where mental health has been the concern around that. And it's been interesting that that's actually gone down over time between 2012 and 2022. So I've said it's the 11 to 15-year-olds, but in particular, it is the 11 to 15-year-old females that are driving that. And you can see from 2000 to 2021, a significant increase for eating disorder admissions in that group. So the key findings were a large increase, especially in eating disorders and 11 to 15-year-old females. What I didn't show you there is that those admissions have also become longer for all causes. So the number of admissions that are lasting longer than a week, which is a long time for a pediatric admission, because most pediatric admissions are 1 day or 2 days. That's actually doubled in 10 years. What's also interesting is the demographics. I'm not going to make too much about that at the moment, but if you were to look at admissions for asthma, gastroenteritis, respiratory illnesses, so a significant chunk of acute admissions, it's usually poorer kids that get admitted more. So it's usually associated with poverty. What was interesting here is that there was a definite disproportionate, one might expect, compared to other reasons that children get admitted of white females, and actually particularly from the least deprived areas. You can make of that of what you want. It may well mean lack of access, because if you look at the poverty relationship with mental health overall in the community in children, that is not reflected. So it may well be to do with the fact that people are accessing care are not equal when it comes to deprivation via postcode, and we could pick up deprivation, by the way, from postcode. It also might relate to the fact that some people from different demographics present their mental health crisis in different ways. And to pull it all together a bit for the current theme of today, long-standing medical associations. So there's a strong association with longer admission and increased with long-standing medical associations. So things like long-standing medical conditions like diabetes, for example. So just to talk a little bit about the surveillance study, this would be good if we could stop recording on this bit, because I've not published this bit, if that's all right. I was supposed to yell out when that was the case.
Dramatic increase in admissions for eating disorders and self-harm as well, especially in that 11 to 15-year-old age group. And those admissions to paediatric wards that presumably are trying to cope with a lot of very, very sick kids with physical health problems. And clearly that's going to cause tensions.
Yeah.
So who would like to ask a question? You can put it in the chat, or if you turn your camera on, raise your hand, and I should be able to see. I don't see any questions in the chat. Maybe I could start, Lee, by asking, I think we're all familiar with the problem of managing kids with eating disorders, but what about those children who've self-harmed? And that was a very high proportion, wasn't it, of the total? So what sort of arrangements are there for managing them?
Well, ironically, if you look at in the models, because the models that we've used looking at length of stay, take that for example, or being sectioned, which is a logistic model, we've used it as a predictor, self-harm or not, as the predictor, or eating disorder or not. And we've done that because what was really interesting in the granular data in the surveillance study is that people had multiple types of presentations, and I'm sure you can imagine. So there were some social concerns, and there were also behavioural concerns in some children. And if in those analyses, actually, if you've self-harmed, that makes up a significant chunk of who these admissions are, but actually they're the ones that stay the shortest. And so in the models, actually, they predict a short admission, if that makes sense, compared to because we were just looking exclusively at a bunch of children who've been admitted with a mental health concern. If it was self-harm versus the others, actually, it was protective is not the right word, because that's completely the wrong word. But if you understand what I'm saying, it was a predictor of a briefer admission and a less complex admission in terms of being restrained, having a nasogastric tube, for example. So. And I think to some extent the overdose group of children and young people, and including young adults and adult wards, is a well-trodden pathway. and has been around for a long time. It's just that there's just so many more of them. I guess is the point. So people are at least able to do it. And I think there are pathways in place and have been pathways in place for a long time around that. I think the juxtaposition with particularly eating disorders and more sort of acute behavioural disturbances that we've seen are been more tricky because that's the kind of behaviour, and I use the word behaviour lightly, but you understand what I mean, because I know that sometimes behaviour can come across as pejorative, as if it's intentional and it's something you could control, but the kind of presentation features like that are not things that people are used to. So I'm not saying that they find overdoses easier and that we want more overdoses by any means. That's not what I'm saying. But I'm just, if you compare the group as a whole of all these admissions, I think it's the sheer number of them, David, I think really that's the issue.
Well, you mentioned 84% of the total were for self-harm or
Mm.
um, suicide risks.
Yes,
And it doesn't surprise me to hear they're the short admissions because you want to get them off your ward. They're a
yes.
nuisance.
And
In my experience,
yes. And I think
it's
that's
the
where yeah,
attitude.
yeah, I agree entirely, and I think that's something we need to change. And I think I was perhaps a bit pejorative about the outlook of staff because I think we've got a new generation of trainees, for example, who are coming through who are very switched on to mental health, who've basically grown up through their training, realizing this is core work and have been motivated to get better at it. So I think there's lots of hope for the way people are doing it. I just think we just need to know how we do it better, and we'll need some element of co-working. But you're right. I mean, for overdoses, for example, that well-trodden pathway of admit, check paracetamol levels, put up a medication to protect your liver whilst you're waiting for those levels, or stitch you up if you cut yourself. Then speak to a child and adolescent psychiatrist who's on call, and then make a plan around that. And then the child and adolescent psychiatrist often being able to tee up with the community CAMs. I think that in the process tends to work better. The attitude may not be right, but I just think everyone's got a bit more complicated, and so you've got that bolt on with other things. I think that's where the major challenge is, and also what's also interesting, and then we saw this in the pandemic, is the number of new presentations de novo. Whereas I think in the past, perhaps children being admitted to children's wards were generally known to a CAMS team, or would maybe even be known to the emergency department or known to the paediatric team. And you may have seen them 3 times that year, or they sort of come in and there's already a relationship. And then because community CAMS already know them, there's a network to feed back into. I think the challenge with the number of increased cases has been you're starting from scratch. And so you don't have that community backup in the same way you do, but you don't have it in terms of knowing the family and the safety net. So I think the de novo cases, which we noted during the pandemic when we were seeing a lot more of these, has been another challenge around the self-harm and presentations with acute sort of behavioural disruption, because there isn't that soft landing for people that has existed in the past when they're known, if that makes sense.
Yeah, well, thank you very much, Lee. Okay, well, we better let you get off and get back to your
Yes, thank
your
you.
emergencies.
And can I just say thank you so much for inviting me, and
Well,
thanks for.
thank you.
Okay, bye-bye. Bye.
Okay, bye. Okay, so we move swiftly on to Anna Kolesnik. Now, Anna's a research fellow working with the Dubowitz Neuromuscular Center and with my team at the Institute of Child Health, part of a very magnificent study that was set up by colleagues in the DMD world, both in the UK and in Europe. Francesco Montoni at the Great Ormond Street Hospital and Institute of Child Health are looking at this condition, Duchenne muscular dystrophy, which I'm sure everybody's heard of, but will perhaps, if they know anything about it at all, think of it as a muscular wasting disease, but which our recent research has found really has quite profound impact on mental health as well, directly and indirectly. So Anna, over to you.
Thank you, David, and thank you for your introduction. Let me just share my screen. Here we are, and hope you can see the slides. Right, so thank you everyone for being here. I think the talk will be slightly different to the previous one, but hopefully I will give you all an introduction into the mental health and neurobehavioral aspects of Duchenne muscular dystrophy, and also provide you with some background on DMD itself for those who are not familiar. So overall, Duchenne muscular dystrophy, or DMD, as I'll be referring to it in the talk, is characterized by problems in physical functioning. This is mostly caused by a genetic mutation within the dystrophin gene, which is X-linked recessive condition, so mostly affects males. It's characterized by progressive muscle weakness and issues overall with kind of respiratory and cardiac, and also within the central nervous system. Overall, it affects 1 in every 36,000 male live births, and we do note some female presentation. So they're called manifesting carriers, and about 8 to 10% of females do present with muscle weakness, fatigue, and pain. And just to give you some overview of the functional decline in Duchenne muscular dystrophy, so this is untreated progression. So within the first 3 years of life, any affected infants and young boys with Duchenne muscular dystrophy will show marked deficits in gross and fine motor milestones, where typically this kind of DMD will be diagnosed through a genetic screening. Around the age of 5, there's prominent muscle weakness observed, and without adequate care and corticosteroid treatment regime, by about age 10 to 12, around 70% of boys will lose ambulation and require non-invasive ventilator support at night by about age of 15. Unfortunately, around kind of age of 20 plus, there will need to be more invasive respiratory management and any kind of cardiac management, and overall kind of increased risk of mortality. We have increasing kind of improvements in standards of care, including long-lasting and long-acting corticosteroid treatments, which have improved and kind of increased overall kind of life expectancy, but also delayed this initial loss of ambulation. Outside of the muscle, we know that there are multiple dystrophin isoforms expressed in the brain, and it's driven by different promoters. So all typically with the involvement of DP427, which is the largest one that you can see here. And this will impact neurons, so any messengers that go throughout the brain, brain structure and functioning. These are the 3 main ones that are involved in brain function. So anything with affecting the long protein, so the DP247, DP140 affects brain and kidneys, and DP71, which is kind of ubiquitous across the brain. And overall, for those with kind of interest within what actually happens when there's dystrophin missing within the brain, we have some findings from 2012, but more recent confirmations from about 5 years ago, to say that this loss of brain expressed isoform disrupts GABA A receptors. So really anything to do with inhibitory signaling and control in the brain. And this leads to GABA receptor clustering at postsynaptic sites. So there's neuronal hyperexcitability, which is also linked to attentional regulation, impulse control, and emotional modulation. Cognitive challenges within this population are relatively well characterized. We know that the IQ of these children and young people tends to be around 1 standard deviation below population mean, with 30% being within the intellectual disability range, so IQ of under 70. Difficulties tend to be around working memory and verbal skills, and are typically non-progressive, although longitudinal data is still kind of needed to actually understand the long-term projections of cognitive manifestations. In addition to this, we have increasing evidence for psychiatric and behavioural comorbidities. This is particularly important just before I discuss prevalence with you, because as I mentioned, life expectancy in Duchenne is increasing. And we are now beginning to understand the psychiatric and behavioural comorbidities. We want to make sure that we're embedding these within the care frameworks and making sure that we can improve quality of life for these individuals and their families. And yeah, so as I mentioned, so we have several prevalence studies in terms of how widely distributed these problems might be. ADHD tends to range between 11 and 18%. Autism spectrum is around 7%, and anxiety around 24%. Depression is variable. At the moment, around 11%, but commonly reported in older individuals and caregivers. And is tend to be classified as a secondary manifestation rather than a primary of DMD. And the main concerns for individuals are learning difficulties, emotional regulation, and social integration. While for caregivers, it tends to be high levels of stress, burnout, and anxiety related to disease progression. And there is, of course, a bidirectional effect between physical health and these behavioral difficulties. So I will introduce you to our BIND consortium, which I'm speaking on behalf of today. And BIND stands for Brain Involvement in Dystrophinopathies, and this project was set up by Francesco Montani and Professor David Skuse and several other PIs across Europe to provide a comprehensive assessment across different centres of this population. So today I will mainly talk to you about the paediatric results, although we have some results from adult Becker patients and young Becker patients as well, which is another muscular dystrophy which is less severe. And we also recruited participants based on their genotype group. So as I mentioned before, you have different types of mutations which are associated with sort of different levels of dystrophin loss. And we also wanted to see how these isoforms manifest behaviorally and within these kind of issues. Right, so, and just to give you a little bit more background, this is a really large project. So it ran in 3 parts. The first part was in online assessments, where we mainly identified and recruited participants. And this was around kind of the time of the pandemic, where we asked parents and young people if they wanted to do it on their behalf. On their own behalf to kind of complete a set of questionnaires online. And this was then followed up by in-person deep cognitive phenotyping assessments within each centre. And so today I will talk to you about the results of the DORBA study. So this was a comprehensive online protocol that was delivered with a set of measures. So the DORBA, as some of you might know, is a package of questionnaires which assesses DSM-5 psychiatric diagnoses. We asked parents to complete these set of questions, but also they have text boxes for responses to comment on several symptoms. And then trained clinical psychologists review those responses and make a judgment on whether they would kind of suggest that there might be a diagnosis present, and then kind of in clinical practice, that would mean that they would be hopefully followed up for an assessment. But this was all only done for research purposes. We also administered a strengths and difficulties questionnaire, which is very common kind of as routine assessments to look at mental health and kind of adaptations within these groups. And we have our 4 isoform separated groups. So we have the DP140 plus, where most of the kind of isoform is preserved. It's associated with a relatively milder cognitive profile, but also kind of physically they tend to be kind of the least affected. We have a DP40 unknown, where the status is unclear, and there's a variable cognitive and motor phenotype. DP140 minus, where we know that the DP140 isoform is disrupted and is associated with greater neurodevelopmental impact. And last, we have the DP71, which is a much rarer mutation where dystrophin is almost fully absent. And this is the most impaired phenotype. As you can see in the participant numbers, we were only able to recruit and successfully test a small number of these children, and only small number of kind of parents with children of this isoform. This is partly to do with the severity of the presentation, but also reflects the rarity of this mutation within the overall DMD population. Right, so I will talk to you about what kind of problems we reviewed across the European cohort. So we were able to successfully rate 238 assessments. This means that parents fully completed them and they went through the assessment, which typically was around 45 minutes to 1.5 hours for the online interview. From the 238 participants, about 50 were rated as positive for a Dober sign diagnosis, which is about 21%. 20 of those were ADHD diagnoses, 19 for anxiety, 16 for autism, and 5 for oppositional defiant disorder. This arrow is meant to be for anxiety. So anxiety type disorders are a group, is an umbrella term for separation anxiety, specific phobia, social phobia, and most of the diagnoses were generalized anxiety. This is very similar to some of the prevalence studies that we see. So nothing really was very surprising here. We didn't record any OCD cases, which are present in some of the kind of more adolescent populations, or depression. But again, a lot of the sample tend to be younger children with a mean age of 10. We also noted some differences in distribution of diagnosis per mutation group. So DP140 overall, there were no significant differences in the number of doable-based diagnoses across DP140, DP1 mutation deletions. However, we note that the DP140 minus group has more autism diagnoses relative to all the others, whereas ADHD and anxiety tended to be equally distributed. We also note presence of multiple diagnoses, where 9 children who had one diagnosis on the Dober received more than one. And as you can see, they were primarily within the DP140 group. And within this group, the score on the Strengths and Difficulties questionnaire, which I will cover in 1 minute, were significantly higher than the population norms, but also the DMD group average. So kind of within thinking about the kind of isoform specific analysis, we can tell the DP140 minus group overall is not just more impaired physically, but also we will have these we're likely to have these problems present as well. Right, so what we were able to do within our sample to contextualize the data on children with DMD was compare it to 2 comparison groups. One of them was the Imagine ID cohort, which David Skuse has been leading on as well, but Jean Wollstonecroft, who should be on this call. So this is data from a UK-based sample of children with intellectual disability due to a known genetic diagnosis. And what we were able to do within this group, we were able to match, so 2 to 1, between our DMD children to the Imagine ID cohort, and we matched this data set based on biological sex, chronological age, but also parent estimated mental age. So we try to really kind of match the children across their overall profile. And as you can see within the comparison of the Dober diagnosis and the SDQ, the children within the Imagine ID cohort tended to exhibit a higher level of problems relative to the DMD cohort. The second comparison group that we looked at was normative data from the UK's National Survey of Mental Health of Children and Young People from the 2017 kind of data set. And we're able to also compare that within our DMD or bind cohort. And we found that DMD children exhibited significantly higher proportion of Dober sign diagnoses, high rate of ADHD, ASD, and anxiety type disorders, but not oppositional defiant disorders. Comparison of SDQ, their strengths and difficulties, found that so children with Duchenne tended to have slightly higher total scores, as well as high emotional symptoms and peer problems. However, there were no significant differences in hyperactivity problems. And looking kind of more deeply within our cohort itself, so we examined data from 7 sites and 6 countries. We had 2 sites in the UK. We did actually look at some cross-cultural variation. So as you can see, in terms of the prevalence of diagnosis based on the Dober, the Netherlands, UK, and Newcastle had relatively high prevalence relative to quite low numbers in Italy. On the SDQ as well, let me get my pointer. Italy had the lowest reported difficulties across the across the children. There were no differences in parent-reported peer problems. And in Newcastle, the parents tended to report the lowest levels of prosocial behavior. There's many differences for cross-cultural variation. We try to mitigate this by having the same raters, so everything was rented centrally in UCL. So we're not kind of expecting that there's any differences within that. Everything was translated and interpreted by us. However, cross-cultural variation in reporting of mental health concerns has been previously noted across literature in kind of multinational studies. We know that health system structures, psychological services availability, and caregiver priorities and expectations tend to influence how behavior is interpreted. So this could be partly why we're seeing these sorts of patterns. And in future, we're thinking about using country-specific comparison groups. So thinking about the normative data that we had from the UK, and thinking about if we can source kind of country-specific controls. Lovely. So that's a short overview of the study itself. And I wanted to introduce you to a screener. So this is something that has resulted as part of the large efforts of the BIND Consortium. And just to note that this is currently under review for publication. This is a screening tool that's been developed for selective and sensitive identification of these additional kind of neurodevelopmental difficulties in DMD to try to help kind of within kind of care settings to identify potential behavioral red flags in children with Duchenne. So this is an 18-item questionnaire. It takes about 5 to 7 minutes for parents and caregivers to complete. And it has a 5-point Likert scale on intensity judgment from none to extremely concerning. We also have 11 questions on history of previously given diagnoses and 6 questions on impact and unmet need. And so through some statistical analysis, so the kind of the validation of this questionnaire will be kind of published hopefully in the next couple of months or so. But the study revealed that a score of 20 and above was identified as a red flag for risk of any brain-related comorbidities with relatively high sensitivity and specificity levels. And this is again some preliminary data to look at some wider issues that were captured by the screener. We're able to collect data from 835 individuals with DMD across 11 different, collected across 11 different languages in 38 countries. It demonstrated high internal consistency and high correlations with a subsample that have completed both the BIND study and the BIND screener, which is about 90 individuals. And as you can see, we have relatively high prevalence rates. So these tend to be a lot higher, than the ones we reported, but also in a lot of cases higher than published data. And this could be due to us capturing quite a lot of data outside the EU. So we're capturing data from Turkey, Russia, Brazil, China. So there are some kind of data that we're capturing that has never been published before. And also, I wanted just to highlight the column of impact and unmet need, where we're looking at kind of over half of the parents being concerned for around behavior of their children, and over 60% wanting to receive further healthcare and support for the behavioural and neurodevelopmental problems they're developing. We're hoping to develop and roll out this tool in future use, but also compare it with emerging screening tools for this population, including DMAND and Bell's questionnaire. So just to quickly summarize, as I realize I'm running over a little bit, I hope that this talk has highlighted to you that Duchenne is much more than a muscle condition. Within the BIND project, we've collected data from parent and in-person assessments from large European cohort, and that the DORBA tool can be highly effective in capturing the complex behavior profiles in dystrophinopathies, offering scalable genotype-sensitive approaches in kind of thinking about earlier diagnosis and identification of neurobehavioral problems. We also recognize about the time that it takes for parents and carers to complete something like the DORBA. So in larger clinics, probably something like the BIND screener would be a time-efficient way to pre-screen red flags, but DORBA might serve as a valuable second-line assessment, providing more rich diagnostic insights. And I want to acknowledge the working group of the BIND project that has been involved in collecting this kind of online and in-person patient data, but also the European Union Horizon grant from 2020 and our lovely families that have been providing all this data for us. Thank you very much.
Thank you very much, Anna. Excellent. So we have a few minutes for questions now. We're in theory until 1:15, but let's see. Any questions for Anna about this study? So there's a very diverse group of people in the audience. One of the most striking findings that Anna made was the divergence of Italy from the other data that we collected. The children in Italy had the least mental health problems associated with their DMD, according to their parents. They were also the most pro-social. Is anybody here from Newcastle? They were the least pro-social. So is there a cultural difference between Italy and Newcastle, I ask?
I think with Newcastle, because we work closely with the site, some of the children were actually in care. So it's quite a different sample. And again, in Italy, this was more of a specialized clinic focusing on children with DMD and also intellectual disability and impairment. So we have to think about individual site variability, but also how parents are reporting mental health symptoms and how kind of how they are culturally in terms of their interpretation of kind of their children's behavior as well.
I think that raises, I mean, I'm not entirely being flippant here. I think it raises an important question as to the way in which we go about measuring mental health issues in children, where it's a quasi-objective, asking parents to rate their child's behavior, but also potentially problematic because of cultural differences in perception as to children's characteristics. I think the general point here is that these children have a serious physical health problem, which has certainly, until maybe a decade ago, dominated the clinical picture. And when they were being treated, the focus was very much on their physical capacities, their progressive weakness, and not necessarily on any mental health problems, or those might have been thought to be secondary to the physical health problems that the children had. But I think the research that Anna's presented has demonstrated that there is an association with mental health problems that are actually related to the biological features, so we say, of the condition, not necessarily just to the severity of the physical symptoms that child has. And other work, which Anna hasn't talked about, but has also been going on in parallel with the studies of children with this condition, are animal studies, for example, mice, that have been created, as it were, to have a genetic anomaly that is similar to that in humans, and the consequences of that on their cognition and social behavior has been studied as well, and it's clear that there are parallels there. Any questions? I don't see anything in the chat. Anybody?
I think there are a couple of questions for Lee, but I definitely can't answer those.
Right. No, I'm afraid, sadly, we can't ask Lee. He had very important things to do. No questions at all. Well, thank you, Anna, for this very good summary of what was a complex study. But I think you've explained very well how we went about doing a project, pan-European collaboration, which is a good thing to promote. And indeed, with our colleagues across the Atlantic as well, potentially, I believe. So if anybody wants to ask anything about the techniques that we used, then please do get in touch with us. All right. Okay. Well, I think we'll end the seminar there. Thank you both to Anna and to Lee for their presentations, and thanks everybody for attending. Okay. Bye for now.
Thanks, everyone.
Bye-bye.